Thanks very much, Jim, and welcome everybody. For those who don't know me, I'm Danny Rayson. I'm a medical oncologist here at the QE2 Health Sciences Center in Halifax. I've been heavily involved over the past few years in the area of neuroendocrine cancers, and our focus in Halifax has been building a very broad-based, functional, multidisciplinary team. And I think among the speakers you'll hear today will be evidence of that having been accomplished, including reaching into New Brunswick with Dr. Nicholas Finn. So we're trying to expand expertise throughout Atlantic Canada for this rare group of diseases. I'd like to first thank very briefly pNETS Canada as well as the sponsors for coming to Halifax to allow us all to share ideas and thoughts about this. As well, two special people to thank on top of Jim's thanking Gillian Reed, who's our on-the-ground coordinator for all things technical and non-technical, and Fleur Mainville, who you've heard last night and this morning, a fantastic musician who's played with the Tragically Hip, the Bare Naked Ladies, and now for you guys. So, thanks very much. I'm not sure who to thank for bringing the weather. I'm not sure if it's pNETS Canada or just you guys, but thanks for the sunshine. And for those patients and families of particularly who I've been involved with here, I'm sure you're wondering, it's the first time in my life the guy has ever been on time, so try and get over your shock. And you'll notice by the schedule that the person who has the last word at this meeting, as well as in the clinic every day, Helen Searle. So for all the patients who've been under our care, you know that Helen always tells us what to do and how to do it. So with that, I would like to introduce Dr. Ozgur Mete, who is a consultant endocrine pathologist at the University Health Network in Toronto. Originally from Turkey, he did most of his training in Istanbul and has worked under the guidance of Dr. Sylvia Asa, who is a quite renowned endocrine pathologist both nationally and internationally. And Dr. Mete is going to talk to us about some of the challenges in the pathologic diagnosis of these rare conditions. Thanks very much, Dr. Mete.
So first of all, I would like to thank the organizing committee for inviting me for these beautiful events, and I'm very happy to be one of your guests, and I would like to get involved actively in your tumors and in your diagnosis. So basically, for those who doesn't know me, I'm an endocrine pathologist, and I diagnose your tumor and as well other endocrine cancer. So my objectives will be focused on how we diagnose endocrine tumor, neuroendocrine tumor. And I would like to highlight the spectrum of the neuroendocrine tumor, the limitations that we do have, and as well some genetic predisposition associated with this spectrum. And I would like to highlight some novel aggressive markers of predictive and prognostic markers related with your disease. So first of all, I would like to give you a basic definitions of endocrine system. The endocrine system is primarily a network of glandular organs that produce and secrete hormones, but it also includes some scattered cells throughout other organs. So the second part we call diffuse neuroendocrine system. And the term neuroendocrine has been used to designate diffuse neuroendocrine system because of some similarities that these cells share with neurons. Neurons are like our brain cells, and they have some characteristic markers, and this is why we call them neuroendocrine. So in this chart, I wanted to highlight the embryogenesis. I will explain to you what is embryogenesis. So all humans, we develop as an early embryo, and the development of embryo is called embryogenesis. And during the embryogenesis, humans' organs are mainly developed from three parts of the embryo. One is called endoderm, here the term, and the second is ectoderm or neuroectoderm, and the third part is mesoderm. So basically, our neuroendocrine cells are coming from neuroectoderm and endoderm. The importance of these one is, as here I showed, this is this primary network of organs and cells scattered throughout other organs. And most of our neuroendocrine cells are derived from endoderm, and the rest from neuroectoderm. And adrenal medulla and periganglia and C cells of thyroid, and as well some cells in the skin, these are called Merkel cells, are coming from neuroectoderm. So the importance of that, for example, some tumor arising, we call neuroendocrine tumor arising from adrenal medulla periganglioma, and tumor arising from periganglia, we call, adrenal medulla, we call sympathetic periganglia or pheochromocytoma, and tumor arising from periganglia, we call them periganglioma. The importance is this one. We can highlight this tumor by using MIBG techniques, and the other tumor we cannot do that for. And the reason these tumors have different characteristics because they are modified neurons. So basically the definitions for neuroendocrine tumor and cells, they have the capacity to produce hormones that we call neuropeptides. And they have some specific morphologic and immunohistochemical, I will explain this term a bit later, and contain some features that we call secretory granules and as well some neuroendocrine markers. So this slide I made it to highlight how we can highlight these cells and these tumors. So each human cell has two main parts. One is we call nucleus, and it contains our DNA, our chromosomes, our genetic material. And the second part is what is in white and with a lot of stuff inside. It's called cell cytoplasm. And the cell cytoplasm contains some organelles and some vesicles that are important for us, and some other markers. And we can use some markers associated with the cytoplasmic contents of neuroendocrine cells, such as chromogranin, synaptophysin, neuron-specific enolase, PGP9.5, CD56 or CD57. So these are markers that we can use to highlight these cells. So okay, this is what we have in normal life. So this is a biopsy sample, and I can use a technique. We do have, as a pathologist, some techniques we call immunohistochemistry. What is immunohistochemistry? So we do have basically some antibodies, and we can target these antibodies to the antigen or some markers located in the cell cytoplasm of our neuroendocrine cells, such as chromogranin A. So the blue area is the normal epithelial cells, other non-neuroendocrine cells, and the red one, the positive stainings, is for chromogranin A antibody, and I can highlight the normal distribution of our normal neuroendocrine cells. Here, this is thyroid. The four black, brown, or red appeared positive staining is just for parafollicular C cells. Here, this is pancreas, and I can highlight using this antibody our normal-looking pancreatic islet cells. Here, this is our skin sample, and in the outer surface, you see some cells scattered with other cells, so these are our Merkel cells. And another important of these neuroendocrine cells, and as well tumor arising from these cells, is the presence of some vesicle in their cytoplasm. We call them neuroendocrine or secretory granules. Why they are important? Because the reason I want to pay attention to this one, we do most of the markers that we are using are associated with these neuroendocrine granules, secretory granules, and more importantly, they contain the hormones. And the size, so for example, this is one of them, and another cells with different morphology, and this is another normal cells with different kind of vesicles, black dots. Their size, their shape, and their number varies basically based on the cell types and as well based on the differentiation. So what does it mean, differentiation? Basically, neuroendocrine tumor have can be categorized into two classes of differentiation: well-differentiated neuroendocrine tumor and poorly differentiated neuroendocrine tumor. When you do have a well-differentiated tumor, it's share the same spectrum of the non-tumoral cells. What does it mean? If it arises from B cells of pancreas, here this is typical beta cells, so we can see this kind of structures in the well-differentiated pancreatic neuroendocrine tumor that's produce insulin. And in other terms, if we are dealing with a poorly differentiated neuroendocrine tumor, we will have less hormones and less secretory granules and some kind of difficulty associated with in terms of diagnostic marker. I will highlight this feature a bit later. And another important feature of these cells under the microscope, so as I told you before, each cell has nucleus. Here this is shown beautifully dark blue, and the pink side is the cell cytoplasm that contains our granules, secretory vesicles, and the nuclei has an appearance that we call salt and pepper, because black pepper fits to this small dots we can see there. So let's have a look to the terminology used for this tumor. The terminology has been evolved over the years and from top to down, and it started with Dr. Obendorfer by the introductions of carcinoid in 1907. So Dr. Obendorfer has an important feature for this tumor because he was the first man who distinguished clearly what we now call neuroendocrine tumor of the GI gastrointestinal tractus. And he has an importance for me because where I did my training, anatomical pathology training at the University of Istanbul, he was the former person who established the Department of Pathology in my university. So this is a slide from a patient from an ileal, from small bowel neuroendocrine tumor patient. So we took a sample. So this is from 1907. This is a slide from his original personal archives, Dr. Obendorfer archives. So if you look carefully, you have two small lumps here. So these represent what we are seeing here under the microscope. Well circumscribed nodules that he used the term, he gave the term carcinoid, which means carcinoma-like. If we go to his first description, he described this tumor as small, multiple, harmless tumor, and he even thinks they don't metastasize. But actually, it took for him 22 years to accept that they can have a metastatic potential. So still, the term carcinoid is still, we shouldn't use because it doesn't have any biology, because it reflects most of the time the clinical picture. But still, we don't have any consensus on which terminology we should have. And the current terminology of neuroendocrine tumor varies by the anatomical size of the tumor. And some important, I would say, site-specific tumors, such thyroid medullary carcinoma, Merkel cell carcinoma of the skin, and pheochromocytoma and paraganglioma from adrenal medulla and paraganglioma still maintain their former label. But if you look carefully, still for lung and thymus, one of our colleagues still used the term carcinoid tumor, that I think we should abandon this terminology. Let's have a quick look to the clinical and biochemical features of this tumor. We know that, we all know and we are aware of this, the incidence of neuroendocrine tumor has been increased over the past 30 years. But the reason is probably we diagnose them more often by using more sensitive and specific tools in clinic lives and as well in pathology. And in terms of the anatomical distributions of the neuroendocrine tumor, if you exclude some site-specific tumors like skin tumors, skin neuroendocrine tumor, thyroid and adrenal medulla and paraganglia, gastrointestinal system is the most common localization for this tumor. And we do have some circulating markers to diagnose this tumor, and most popular is chromogranin A, pancreastatin, and some hormones that allows us to decide if this tumor is functioning or not. And based on the hormonal excess, we do have some clinical syndromes that I'm sure my other colleagues will cover this one. But I would like to highlight one feature. as I told you before, we do have some antibodies that we can target some markers in the neuroendocrine tumor end cells in order to highlight their hormone context, in order to highlight their other features. And one of these features we can try to find if the tumor contains tumor hormones associated with or not. So imagine this is a pancreatic neuroendocrine tumor, and I used two antibodies. One is glucagon, and the other one is ACTH. And the tumor stained positively the red area for these two markers. So can we say this is a functioning tumor? The answer is no. We cannot tell by looking to the immunochemistry if this tumor is functioning or not, because it should be defined on the presence of clinical symptoms. And we know that most of the neuroendocrine tumor actually are multi-hormonal by immunohistochemistry, and usually one single hormone is responsible for the clinical symptoms. And the issue of functionality actually impacts on the terminology for this tumor. And any patients with symptoms, we call them to have functioning neuroendocrine tumor or syndromic neuroendocrine tumor. And without any clinical symptoms, we use the term non-functioning or silent or non-syndromic neuroendocrine tumor. The importance of this feature is that the non-functioning neuroendocrine tumor usually becomes important or clinically apparent when they develop metastatic disease or when they compress adjacent organs and they cause other symptoms. And right now, I would like to highlight my subject, my topics, how we diagnose neuroendocrine tumor. So the first part starts with the gross examination. So I would like to a bit explain to you what is this. This is a pancreas from a young patient, I would say. And this is cut longitudinally, and it's revealed two main tumors. One is here. So this is the normal looking area, a quite fatty looking, I would say yellowish and lobulated appearance. But here there is a firm, very distinct whitish nodule, small one. And there's another one, if you look carefully at the edge, a bit larger than this and with a lot of hemorrhage. So this is a pancreatic neuroendocrine tumor, and this patient has two tumors. So this have an underlying pathogenesis. This patient have something that allows to that patient to develop multiple lesions and some microscopical lesion. This patient has actually, what I will mention a bit later, a MEN1 syndrome and multiple endocrine neoplasia type 1. And this is a small bowel resection, a segmental resection. And here, if you look carefully, this is the normal looking area. There is a lump a bit different than the other surface, and this is again another neuroendocrine tumor. And this is another pancreatic neuroendocrine tumor, a large mass with hemorrhage and cystic change. So the morphological features can be quite variable and are important for us, but I wanted to highlight a bit. And in terms of what we are seeing under the light microscope, they can exhibit a variety of growth patterns as I've shown here. And histological patterns that we are seeing are not specific to tumor type and as well to functional status, but we do have some exceptions. When we see under the microscope some amyloid deposition, some pink homogeneous material deposition within the tumor, we always think about the possibility, if it's in pancreas, in selenoma, if it's in thyroid, we should think about the possibility of medullary thyroid carcinoma. And another thing which is important for us as well, when you see these small calcification, we call them psammoma bodies, with some glandular structures, we suspect the possibility, we suggest the possibility of somatostatin producing tumor. And in terms of cytological features, I mentioned before, well-differentiated tumor will have the same features, salt and pepper nuclei, and the typical morphological appearance as I've shown here. But sometimes we do have a variety of pictures, different morphological and cytological features. And I want to highlight the presence of clear cells, because when I see clear cells within a neuroendocrine tumor, I should suspect the possibility of another genetic syndrome, which is VHL. So we do have some morphological parameters, but we look for as well for other explanation for this tumor. So basically, you should ask me how you do diagnose neuroendocrine tumor morphologically. We check the gross feature. Then after we took sample from this tumor, we look under the microscope and we check if they have salt and pepper nuclei and their specific, or I will say, the spectrum of their morphology. And then after we ask to ourselves, could this be a neuroendocrine tumor? At this point, we have to confirm if this tumor or these cells have a neuroendocrine differentiation. And in order to confirm, we use some markers that I'm showing here, synaptophysin and chromogranins. Some limitations are associated with chromogranin A. So we do have a lot of chromogranin, and most used one is chromogranin A in tissue. And chromogranin A is not really seen in neuroendocrine tumor arising from rectal mucosa, rectal carcinoid, or I will say rectal neuroendocrine tumor. And another thing, poorly differentiated neuroendocrine tumor will have less secretory granule, means less chromogranin A, and I will have maybe a difficulty to prove chromogranin A positivity in this tumor. The second step is to show the immunohistochemically, by using immunohistochemistry, the hormone contents of this tumor. So we can detect as many hormones as we want, and we usually do in our patients with neuroendocrine tumor. When I deal with neuroendocrine tumor, even though it's not symptomatic, I always perform the hormone profile for this tumor. And another story, when we are dealing with metastatic neuroendocrine tumor, usually liver biopsy, neuroendocrine tumor morphology, we can confirm this tumor by using chromogranin A, synaptophysin, the neuroendocrine differentiation. And the second problem is where it's coming from, because clinically this is a metastatic neuroendocrine tumor of unknown primary origin. So we do have some markers as well to find out where this tumor may come from. So, for example, in the case of TTF1, this is a transcription factor. This is a marker that we are using in tissue that allows us to distinguish lung and thyroid from other neuroendocrine tumor. And we do have some other markers for pancreas, such as islet1, PAX6, or PDX6, and others as well. I told you before that tumor differentiation has an importance for us because the more let's say this, because the definition is it refers to the extent of resemblance of their normal parts. And if we have a well-differentiated tumor, it's a good sign. And if we have a poorly differentiated tumor, it has a difficulty in terms of diagnosis of neuroendocrine tumor and as well response to other treatment. So this is an example. This is a well-differentiated neuroendocrine tumor. It mimics the normal cytology and the normal growth pattern arising from the tissue. And this is another one. When I look this one, lymphoma or other carcinoma can be possible. So I have to use other marker to confirm if it's a neuroendocrine tumor, high-grade differentiation. And one of the other important features of the high-grade neuroendocrine carcinoma, or I would say poorly differentiated neuroendocrine tumor, is they have high proliferative activity. How we can assess the proliferative activity of this tumor? We can look under the microscope and we can just count the mitotic figure, which shows the proliferation activity of these cells. Or we can use another antibody, which is called Ki67, or the synonym MIB1, and we can try to find out the percentage of the proliferating cells. This is an important feature because I will mention later that we are using some new grading system that we will use this proliferation activity. And another thing, poorly differentiated neuroendocrine tumor has less secretory granules, less vesicle in their cytoplasm, means less chromogranin A in tissue samples, and less hormones sometimes, and they are resistant in most of the cases. So this is a case. This is a recurrent neuroendocrine tumor. It's in skin. It's not Merkel cell carcinoma. And when you look at this one, first of all, you don't think about the possibility of neuroendocrine tumor. But if you know about this entity, you can order synaptophysin and chromogranin A and confirm the neuroendocrine differentiation in this tumor, and then after prove the high proliferation activity with MIB1 or Ki67. And this is different than the others because it stains the nucleus because the proliferation start in the nucleus, so this is important for us. And in terms of criteria of malignancy in neuroendocrine tumor, I would say the long-term follow-up of neuroendocrine tumor indicates they should be categorized all malignant. But I would say I would like to use malignant behavior instead of malignancy. We know the cytology is important because poorly differentiated tumor have large or small cells, and when you have a tumor with high mitotic activity and high MIB1 or Ki67 index, it is malignant. And if the patient has a metastatic disease, it's also malignant. And some other criteria, such as invasion to the other structures, or capsular, vascular, or perineural invasion. For this reason, we developed some classification system, and we use grading and staging for this tumor. And as I've tried to show you here, the classifications of neuroendocrine tumor varies by anatomic site of this tumor, and as well, it's different based on the system used. So there is a novel 2010 WHO World Health Organization gastroenteropancreatic neuroendocrine tumor classification that we are using in our department as well, and it includes basically, this system used the term neuroendocrine neoplasm of tumor and neuroendocrine carcinoma for high-grade tumor, and it also contains a terminology called grading. So what is tumor grading in neuroendocrine tumor? Tumor grades actually refers to the degree of the biologic aggressiveness, and it is also related to the differentiation of this tumor. And as I mentioned before, tumor differentiations refers to the extent of resemblance of the normal cellular part. And basically, neuroendocrine tumor has two types of differentiation: well-differentiated neuroendocrine tumor and poorly differentiated ones. And the grading system uses actually basically three-tier system. We do have grade 1 tumor. We call them low-grade neuroendocrine tumor, and the other one is grade 2, intermediate grade, and the third one is high grade. And the grade 1 and grade 2 tumor actually what we call well-differentiated neuroendocrine tumor. And grade 3 tumors, which are high-grade tumor, are poorly differentiated neuroendocrine tumor. And why this is important? We use, in order to assess this grading system, the proliferation activity of this tumor. We count mitotic activity under the microscope. We use immunohistochemistry to assess their proliferation marker by using an antibody called Ki67 or MIB1, and we provide a labeling index for this marker. And we know that high-grade neuroendocrine tumor are extremely aggressive tumor, and low-grade tumor, on the other hand, they are relatively indolent, and we cannot predict for indeterminate grade tumor, and they can be sometimes indolent, sometimes aggressive. And another important issue for neuroendocrine tumor is staging. Tumor stage refers to the extent of the spread of the tumor, and we use some criteria to make the staging. The size of the tumor is important. The invasion, the extent of invasion in the organs that the tumor arises, and even the invasion to the surrounding organs, and as well the involvement of the lymph nodes or distant metastases are important factor that we use for staging. And a few years ago, there were no TNM-based staging system for neuroendocrine tumor. And now we do have for each site, as you can see, site-specific tumor staging system for pancreas, for stomach neuroendocrine tumor, we call gastric neuroendocrine tumor, for small bowel, for large bowel, for appendiceal tumor, and we have to provide this information in our reports. Let's have a quick look to the molecular genetic and pathobiology of this tumor. Actually, little is known about their underlying molecular pathology of this tumor. And we know that the chromosomal instability, I would say the change in number and structures of the chromosome, has been implicated in tumor progressions of neuroendocrine tumor. And interestingly, mutations in common oncogenes and tumor suppressor genes are not found in most of the sporadic neuroendocrine tumor. This is why we have to explore a bit more this tumor. But on the other hand, a small percentage of this tumor are associated with some well-recognized neuroendocrine tumor syndromes that these patients have familial syndromes. And the 4 well-recognized ones are multiple endocrine neoplasia type 1, MEN1, von Hippel-Lindau VHL, neurofibromatosis type 1, or I will say NF quickly and briefly, and tuberous sclerosis. And I would like to highlight some important features of these syndromes. MEN1 patients are important because neuroendocrine tumor is not the only manifestation of this tumor. And similar thing with other tumors. So these patients will have other lesions or other symptoms or other lesion in their body. But the most important part for MEN1, they tend to have multiple lesions. So when I look to the gross specimen and under the microscope, and they have some morphological spectrum, some microscopic disease and some gross disease, and multiple. So this is an alerting feature for us. They tend to have most often gastrin or insulin-producing pancreatic endocrine and duodenal endocrine tumors, small bowel and pancreas. And for VHL patients, when I see the clear cell morphology, in addition to some fibrous band, in addition to connective tissue process within the tumor, I have to suggest this possibility in my report, saying this patient may have VHL syndrome, so genetic testing is required and as well the clinical follow-up. And we know that VHL patients, up to 10% of them gets pancreatic neuroendocrine tumor. And a small amount of neurofibromatosis type 1 patients get duodenal and pancreatic somatostatin-producing tumor that we know with, I show you the classical morphology with some monomatous calcification and glandular structures. And rarely, tuberous sclerosis patients gets pancreatic endocrine tumor. And in addition to IGI and endocrine neuroendocrine tumor, I would say we do have other familial disease and familial syndromes associated with other tumors, such as paraganglioma. And mutations in STH16 dehydrogenase gene is important for these patients. And there are 4 categories in this group. And we can help by using antibody. Let's say this is a paraganglioma, which is positive for STHB antibody. And this is another patient, and it is negative for this antibody, which means this patient may have this familial paraganglioma syndromes. And I have to comment in my report saying this patient needs genetic testing. And we have medullary thyroid carcinoma, and they are associated as well with other familial syndromes, such as multiple endocrine neoplasia type 2A and B, and as well familial medullary thyroid carcinoma. And they have mutation in the red genes. So my last part is the predictive and prognostic markers related to neuroendocrine tumor. So as I mentioned, biomarkers for neuroendocrine tumor are limited in terms of our resistant cases, but the tumor grade, which covers proliferation activity by using mitotic count and Ki-67 index, and as well the differentiation altogether, and the staging system are important, are critical factor in terms of biology. And we know that I have to explain this one a bit more. Somatostatin is an endogenous hormone. So our cells produce somatostatins in normal conditions. And it has an inhibitory roles in terms of cell secretion and cell proliferation. And because of these results, we target these neuroendocrine cells because they have on their surface some receptors that is called somatostatin receptors. And we use somatostatin analogs to target these receptors, and as well some radiolabeled somatostatin analogs to target these receptors as well. And the important things that we have, in my opinion, it's not routinely done, but it is a good idea to provide for neuroendocrine tumor in terms of personalized treatment, to provide for their hormone, the somatostatin receptor profile. Because sometimes up to I would say up to 80% of neuroendocrine tumor has somatostatin receptors on their surface. And there are mainly 5 types of somatostatin receptors. So let's say, and most of the time, octreotides bind to somatostatin 2 and 5 with high affinity and low affinity with somatostatin receptor 3. So it is the knowledge of the somatostatin receptor profile may help us in terms of predicting response to treatments, and as well for our nuclear medicine colleagues to sometimes to comment on the false positive and false negative results of octreoscan. And we do have other novel markers of aggressive behavior, such as cytokeratin 19, when it's positive in pancreatic neuroendocrine tumor, is associated with bad prognosis. And CA-CAN1, eCadrin, EGFR, AGFR, and KIT, and others on the way. And a recent paper has shown that KIT, which is a marker of the progenitor cells in pancreas, is an independent prognostic factor in pancreatic neuroendocrine tumor. What does it mean? If you have a pancreatic neuroendocrine tumor positive for KIT, it is a bad prognostic factor. And larger tumor and metastatic tumor are associated with beta-catenin and E-cadherin abnormality in this tumor. And same thing for CA-CAN1 in pancreatic neuroendocrine tumor. And recent important knowledge that we know that 1/6 of the pancreatic neuroendocrine tumor harbor mutations in the mTOR pathway, and we can target that pathway. We have some drugs. One of them is called Everolimus, and we use this one basically in metastatic neuroendocrine tumor. And more importantly, it is going to be important to know the status of the mutations here, to predict if this patient will respond to the treatment or not. So this is, in my opinion, in the future we have to have a look at these ones. And other markers, that other new gene mutations, as I've shown here, DAX and ATRXDAXX, and they are associated with better prognosis. And from our institute, Dr. Sarah has already finished this project, but is still working on it for other extension. We know that we call a polymorphism for FGFR4. And some patients in normal population, up to 45% of Caucasians harbor FGFR4 polymorphism for arginine allele, and this patient, when they develop pancreatic neuroendocrine tumor, they have a large tumor and they develop metastatic lesion earlier, and they have less response to rapamycin treatment. So this is another important issue. And my conclusions, I would say neuroendocrine tumor are clinically and morphologically as well are heterogeneous. And long-term follow-up indicate that this tumor should be categorized as malignant. But still, in terms of morphology, it is hard to tell. It is really difficult to tell sometimes if it's malignant or not. But we should accept this tumor as malignant. And as I've shown, little is known about their underlying molecular pathogenetic for sporadic tumor, and some of them are associated with familial syndromes, which is important. And tumor grading and tumor staging are critical factors that we should always provide in our reports, including mitotic activity, including MIB1 labeling index or Ki67 index, and the staging system that refers to the extent of the spread of the tumor. And we need to have a more collaborative studies in large series in order to highlight other novel aggressive markers. And I would like to thank you. I would like to finish my talk by thanking you all for your attention. And it was really nice to be here with all of you. And I would be pleased to answer your questions during the discussion panel. And I would also to thank Dr. Eza to recommend me for this meeting. And I'm very pleased. Thank you.
Thanks very much, Dr. Mete.